Good morning. Welcoming you all to virtual antimicrobial stewardship. So today we have with us very eminent people who on everyday basis do the stewardship. So the antimicrobial stewardship team here is with Dr. Debutius. He is the ID physician. We have the critical care intensivist, Dr. Subair Mohammed with us. We have from the microbiology part, we have Nandita madam with us and clinical pharmacist Anantra, who is leading the stewardship, and the intern, who is Soundarya for the day. So myself, I am Swadhi Saman. I am a clinical pharmacist and I'm a member of FCPI. So let's begin the stewardship for the day. To the intern.
Good morning all. Today we will be discussing about 4 cases in a stewardship perspective. So the first case that we are having is this patient is a 65-year-old male patient who was admitted to the general medicine department. The reason for admission was the patient was having complaints of fever with chills and abdominal pain since 2 days in the left lumbar region, dysuria, and 2 episodes of vomiting. The patient is a known case of hypertension, polio, scoliosis, and status post bilateral inguinal hernia mesh repair on 2016. Now he is having case of recurrent febrile UTI for past 7 months, and he was presented with complaints of fever since 3 days. The clinical parameters of the patient, after admission, he was subfebrile. He had tachycardia and his WBC counts were uptrending since admission. And the CRP was downtrending. It went from 123 to 95. And procalcitonin was positive. It was 19. And creatinine on admission, it was very high, which was gradually downtrending. ESR was also elevated. Regarding the cultures, the patient's blood cultures, a single paired culture was sent and single culture showed growth of GPC, and which was later reported as cones, which is coagulase negative staphylococcus, which is usually seen as a contaminant. Urine culture from 11th November reported on 14th November yielded E. coli, which was ESBL, with a colony forming unit of 1 into 10 raised to 5. And urine routine from 11/11 showed bacteria 4+ and numerous pus cells with pyuria. This was the culture and sensitivity report, which showing resistance to ceftriaxone, showing ESBL E. coli. Regarding the antibiotics, initially the patient was started on injection ceftriaxone for 1 day, but after that the procalcitonin was positive, which was 19. Then sudden onset dyspnea and diffuse wheeze and desaturation was there, and patient was shifted to HDU. So they hiked the antibiotics to injection meropenem 1 gram BD, and injection teicoplanin 400 mg every 48 hours was added when GPC was reported, which was then stopped after it was reported as cones. So the recommendation that we can make from a clinical pharmacist is that the dose optimization need to be done as the creatinine was increasing. Injection meropenem from 1 gram BD could be changed to injection meropenem 1 gram TAD according to the creatinine clearance calculated using Cockcroft-Colt equation, which was 56 ml per minute as of today.
So to Anandram, can you just elaborate on how we are doing the dose adjustments based on Stanford's or up-to-date, how it's done here?
We follow up-to-date mainly. According to Cockcroft-Colt equation, we use the up-to-date formula, and we also calculate using MD calc. So we strictly follow the up-to-date criteria for AK and CKD also.
Okay. To Nandita ma'am, so there was a cons, there was a GPC. Ma'am, can you just elaborate, educate us on that?
Yeah, so the coagulase negative staphylococcus from single blood culture, where you've sent a paired blood culture. I'm not very clear if the paired blood culture means that you've sent two sets, as in it was sent from two different sites. In which case the single blood culture is not relevant at all. And coagulase negative staphylococcus is only relevant if you get multiple blood cultures positive, at least two blood cultures showing coagulase negative staphylococcus with the same identification and susceptibility, from at least two different sites. And if they're taken at different times, then within 48 hours of each other. And generally, if you get a coagulase negative staphylococcus from blood culture, it will be within 48 hours of incubation if it's a pathogen. When it's a contaminant, it will take longer than 48 hours. But just because it has come positive within 48 hours doesn't mean it's relevant. You should get more than one culture positive, at least two.
So, Soundarya, was it a single culture or was it a paired one?
It was a paired culture. It was a
Paired
aerobic
from
culture.
from two different sites.
Yes, ma'am.
Yeah, and only one was positive. So yeah,
Yes,
so
yes.
that is not. So that is most likely to be a contaminant.
Yeah, and they have stopped the ticoplasm. Yes. Dr. Dibu sir and Subair sir, any additions on this case?
Yeah, I'd just like to add a couple of things, comments, to be honest. So from the history, we know that it is, the initial findings, we know that it's most likely to urinary tract infection, which is why they started a gram-positive and a gram-negative coverage in the meropenem and teicoplanin. So that's important to know that when you think clinically there is infection, you try and treat for the most likely infection and you start broad. So you give an appropriate gram-positive cover and a gram-negative cover. And then the whole idea is that when you get the results of the initial blood cultures, you narrow down the spectrum and treat appropriately. So I think that is what I would say is the highlight of this particular case, that you start broad and then narrow down based on your culture and sensitivities. Yep, that's it. Thank you.
Thank you, Dr. Nandita. Thank you, Subir sir. Thank you, Swati. Thank you, Andram. Thank you, Soundarya. So I think this case has a lot of ID inputs into it. So I would try to put an ID perspective to the case. Because Dr. Subir rightly said, when you approach a case, the first thing you want to know, is there a clinical syndrome by which you can name the disease in question? So in this particular case, the patient had fever, patient had lower abdominal pain, and the patient had pyuria. So the clinical syndrome which we are dealing with, urinary tract infection. So that is the first thing we need to understand whenever we approach a case in a stewardship. Once we know if a patient is a case of urinary tract infection, the next question which should come to your mind, is it a community acquired UTI or is it a hospital acquired UTI? If it is a community acquired UTI, as Dr. Subair said, it could most commonly it will be GNB plus GPC. Mostly it is GNB, and among the GNB it is going to be E. coli. Sometimes it could be GPC, and in the GPC it is going to be Enterococcus, because E. coli and Enterococcus are gut organisms, and these are the organisms which is going to get infected in a case of a urinary tract infection. So this broad idea you need to have in order to choose the antibiotic. So if it is a community acquired UTI, then the organism which we want to empirically cover is E. coli. So you have to start with some agents like ceftriaxone or quinolone, which is fine. But in this scenario, there is a clinical overlooking of the fact, because the patient had multiple hospital admissions for UTI. Then it is not a simple community acquired UTI, because the patient has received in the past 1 year, I think 7 urinary tract infection in 1 year, right?
Recurrent UTIs in 7 months, sir.
Oh, recurrent UTIs in 7 months. Yeah. So recurrent urinary tract infections in 7 months means the patient would have exposed to multiple doses of antibiotic. And then you need to understand our starting point is not just a plain community acquired urinary tract infection where you can simply treat with a ceftriaxone. So here what happened is that they started with ceftriaxone and then the patient went critical. The patient we had to escalate the antibiotic to meropenem. The patient had to move to ICU. Inotrope support has to be started. So all those deterioration of the clinical status of the patient happened. So upfront, when we look at these kind of scenario, you have to look at the factor, what is the syndrome, what is the bug, and what is the resistance pattern of the drug which we are anticipating. And based on that, stewardship is not just about de-escalation. In these kind of scenario, you can straight away say that ceftriaxone is likely to be resistant in this scenario. You can escalate, if not to meropenem, at least to piperacillin tazobactam. So at least that much recommendation can be made from the stewardship perspective, so that a rapid deterioration of the patient could have been prevented. So that is one point which I need to highlight. Second is definitely in this patient, once the culture report came, it was a ceftriaxone resistant E. coli, that is a ESBL E. coli. Then as per Merino trial, we are justified in switching to meropenem, and then the meropenem has been started. Antibiotic stewardship clinical pharmacist pitched in, calculated the dose, and understood that we are suboptimally dosing the patient, and dose optimization has been done, with which this combined approach, with which the benefit to the patient is that the patient is currently the patient is likely getting the most appropriate stewardship based therapy. That's all from my side.
So there's one more question. What about the duration of treatment, sir? How long should we go with the duration?
Yeah. So urinary tract infection, if it is a simple community-acquired UTI in a female, you just need to treat for 3 days. So the UTI duration starts from 3 days. And if it is a complicated UTI, like in this scenario, you will have to give a prolonged treatment for up to 14 days. So the treatment will vary from 3 days to 14 days, depending upon the complexity and the recurrent nature of the disease. In simple scenario, 3 days. In complicated scenario, treat up to 14 days.
So for this case, I would like to ask Anandram, there is a specific method that we follow, the 5 R's criteria. So just to give a glimpse of how the 5 R's criteria applies to this particular case.
So according to our stewardship practices, we strictly follow the 5 R's of stewardship. That is the right indication, the right drug, the right dose, the right frequency, and right duration. We critically assess each cases and we follow these criteria. And in this case, the indication was right. The patient went critically ill, so we escalated to meropenem. And according to the cultures, it was an ESBL E. coli. So meropenem is optimum for the patient. But for the dose, here they calculated the dose according to the creatinine clearance when the patient came. So we put forward a recommendation according to the current creatinine clearance. So we couldn't say it was a mistake on their part. So we filed a recommendation for optimizing the dose also. So next would be the frequency. We change the frequency, and for the duration, just like the research said, we will assess that later as the patient gets completely cured. And after that, after the filing of recommendation, we would follow it up and check for the compliance later.
So
That's all.
stewardship doesn't stop just with keeping the recommendations. We follow it up from 24 to 48 hours to check the compliance. We make sure that the clinicians are informed and that the recommendations are compliant. And if not, what are the reasons to it? Okay, let's move on with the next case. Thank you all, stakeholders.
So the next case is this was a 72-year-old male patient who was admitted onto the stroke medicine department on 4th November. He came with complaints of right upper limb weakness, left facial deviation, breathlessness, cough with expectoration. He was initially evaluated in an outside hospital and where he was intubated due to his poor GCS and desaturation. And he was referred here for the further management. On admission itself, ET tube was changed, and FiO2 was 30% and he had increased secretions. He said known case of CAD, anterior wall MI, type 2 diabetes mellitus, psoriasis, and mild renal failure. He was recently diagnosed with left MCA infarct, so status post thrombolysis was done with tenecteplase. The clinical parameters of the patient on admission After admission, he had recurrent fever spikes on 11th and also 13th. And WBC was also uptrending in nature. CRP was uptrending. It reached up to 184 on 9th November. And Procalcitonin was negative. On imaging, outside CT brain showed acute left MCA infract on 31st October, no bleed. Cultures were sent due to the increased secretions and cough and breathing difficulty. And BAL culture from ET tube showed from 4th November, reported on 6th November, yielded pseudomonas aeruginosa, which is extensive drug resistant. And a repeat culture of BAL culture on 9th November also yielded the same difficult to treat pseudomonas aeruginosa, extensive drug resistance. Another blood culture from right IJV central line from 4th November yielded cones. This is the sensitivity report of the pseudomonas aeruginosa that shows pan resistance to all antibiotics. Regarding the antibiotics, he was initially started on piptas and clindamycin injection. Piptas 4.5 gram TAD and clindamycin 600 mg TAD was started. Along with that, they started PrEP prophylaxis, that is injection ampicillin sulbactam 9 gram IV TAD. And since the patient had fever spikes and uptrending inflammatory markers, they high, and when the pseudomonas aeruginosa was reported, they hiked it to ceftazidime, avibactam, and aztreonam, and was treating with the same.
So now we are with an exterior pseudomonas. So before going to the bug, I would like to ask Zubair sir, as a critical intensivist, sir, when you get a patient who was outside intubated and you are sending these cultures, what will be your addition, sir, to this case?
Yeah, hi. So this is a fairly common situation in intensive care where we get patients who have been transferred from other hospital. So their stay in the previous hospital can be for a few hours or could be a matter of days as well. And the distance traveled during this transfer could be anywhere between half an hour to maybe 6 hours, etc. Sometimes even outside the state, sometimes on air transfer, etc. So there's a lot of factors that come into play during this time. What we need to know is that the longer any sort of plastic tube stays inside a patient, so that could be in the form of endotracheal tubes or central lines or arterial lines or urinary catheters or drains, that increases the chance of getting infections in these patients. Plus the fact that they were in a transfer before they came here, it is quite possible that the aseptic precautions that a person should be handling while transferring these patients and looking after the lines is breached at some point, because practically it's almost next to impossible to maintain a transfer with complete aseptic precautions. It is also important to note that many of these patients will have invasive lines because of the fact that after intubation they got hypotensive and they'll be on vasopressors, so central lines will be required, etc., etc. So that is something that we see fairly commonly in intensive care. So what we tend to do is when such a person comes to intensive care, we tend to change the lines whichever are possible and on admission. So that includes changing the endotracheal tubes and sending cultures, usually a mini-ball from the endotracheal secretions. We will change the invasive lines, which includes central line and the arterial line, and send cultures from the old line and send a stab culture or a fresh culture from the newly put in line at a different site. That is the second thing that we'll do. If there are peripheral cannulas that the patient does not require, they will all be taken off. And even the Foley's catheter will be changed as well. So this is something that we do routinely, primarily because of the fact that these patients are quite likely to be either infected or colonized with bugs during the previous hospital stay or during the transfer. So this is something that we routinely practice.
Thank you, sir, for giving such a brief details on what's the importance of infection control in stewardship. Thank you, sir. So moving on with Nandita ma'am regarding the XDR pseudomonas that we have here.
Yes, so the susceptibility pattern, it is showing resistance to all the antibiotics that have been tested. Probably colistin has not been reported. So that is one of the options. So you could ask for the colistin MIC to find out if it is intermediate or whether it is resistant to colistin. We do not report susceptible anymore. So the interpretation is either intermediate or resistant. The other option may be ceftazidime-avibactam or ceftazidime-avibactam plus astoram, although our experience is that most of the Pseudomonas aeruginosa strains are resistant to ceftazidime-avibactam, at least the ones that we have tested. And the synergy also rarely works. It almost never works. So.
Thank you, ma'am. Over to Dibusan.
Yeah. So basically, again, going by the syndromic approach, we already said, we know that it is a case of stroke patient, poor GCS. So stroke patient with poor GCS, they are at high risk of respiratory infection, especially because of the lack of reflexes, and then there will be chance of aspiration, respiratory tract infection. And because it is a hospital scenario where the patient is being intubated, we have to anticipate some kind of colonization with bugs which is resistant to the common antibiotics which we give in the hospital setting. So to start with, it may not have been an infection, but then from the initial point itself, we know that whatever the colonizing agent is an XDR pseudomonas. So that is important. So again, we need to decide whether to treat or not, because initially when the patient at least came here, the fever was not really there. But then after 1 or 2 days, the fever started. But from the starting point itself, since the patient came from another hospital, the epidemiology of that hospital is important. And then from the initial culture, we will get a clue regarding what kind of organism that the patient has been susceptible to, or the patient has been encountered to in the other hospital setting or any hospital setting. So the epidemiology in this scenario is very important. And once we know that this is the organism, that it is an XDR pseudomonas or carbapenem resistant Acinetobacter, then we know that this is the organism which has been colonized the respiratory tract of the patient. Now, when the clinical scenario deteriorates, fever, increased respiratory secretion, oxygen increase in requirement of the oxygen, or new chest infiltrates, then everything suggestive of a ventilator-associated pneumonia. And now we already have a clue that what is the bug which is going to be, so that you can upfront start the appropriate therapy. So that is one thing which we need to keep in mind. Why the importance of doing a WAAW in these kind of patients, even if you decide to treat or not, especially when the patient is coming from a different hospital and the patient was there for a prolonged period of time, just even understanding the kind of organism which has been colonized the respiratory tract is of big value from a stewardship point of view, or even from a clinical point of view, to start the empirical treatment. This is one point which I want to underline and say. Second, regarding coming to this particular case, again, as Dr. Nandita said, ceftazidime-avibactam was resistant in this case. So maybe we need to have a stewardship algorithm when we have these kind of difficult cases. XDR pseudomonas, it is very difficult to manage XDR pseudomonas per se. So even from a stewardship point of view, it's very difficult to manage. So the stewardship team needs to have their in-house protocol on how to manage this kind of difficult or resistant infection. So XDR pseudomonas, if we look at the recent IDSA guideline, this is how it starts. XDR pseudomonas, mostly it will be resistant to quinolone, aminoglycoside, cefepime, ceftazidime, or even carbapenems. So because it is resistant to almost all of this, it is known as XDR pseudomonas. Then how to treat or not? As I already said, are you really suspecting an infection or a colonization? That distinction you need to make. And if the distinction of the clinician is in the direction of the infection, then you treat. Again, before deciding on the treatment, you try to distinguish whether it is a simple infection or a complicated infection. For example, if it is a simple infection like cystitis, even if it is an XDR pseudomonas, and in case if it is sensitive to aminoglycoside, then you can still give single dose of aminoglycoside. So the severity of the infection is also important. But as in this scenario, where the infection is kind of a bit complicated, the ventilator-associated pneumonia is suspected, then you will have to go all out. So what is the agent you will choose? See if it is ceftazidime avibactam sensitive. If it is ceftazidime avibactam sensitive, then you can start with ceftazidime avibactam. But if it is ceftazidime avibactam resistant, as in this case, then you don't have much option but to go with the classical reserved drugs, that is the colistin and polymyxin B. In case of, I'm just briefly touching upon the CRE also, because the scenario demands that. In case, if it is similar scenario, but if it is a CRE, carbapenem resistant enterobacteriaceae, for example, carbapenem resistant Klebsiella, then you will never go meropenem polymyxin. What you will do is that you will add an avibactam. So ceftazidime avibactam, you will add an aztreonam. So ceftazidime avibactam plus aztreonam would have been the choice if ceftazidime avibactam was resistant in case of an enterobacteriaceae. Whereas in case of XDR pseudomonas, it is completely different. There is no added advantage of adding avibactam. So you have to add one of the reserved drugs. So you will have to go with the colistin polymyxin. So colistin polymyxin plus ceftazidime avibactam. Or if it is an aminoglycoside sensitive, then ceftazidime avibactam plus aminoglycoside. Or you will have to go to the classical approach where you will shun the ceftazidime avibactam completely and you will go with a colistin polymyxin plus meropenem based regimen. So this is the basic difference between XDR pseudomonas and CRE, the approach, the protocol based approach. And also it is not that every XDR pseudomonas you need to treat. Look at the clinical scenario, see if it demands a treatment, and if it demands a treatment, then take the right approach.
Thank you, sir, for enlightening us. And sir, should we go for a critical care AST for polymyxin colistin? Ma'am, should we go for that? And currently the patient is in ceftazidime avibactam. So while keeping recommendation, can we go with to stop ceftazidime avibactam and to start with a meropenem polymyxin combination?
Should I take that?
Yes, yes.
I would suggest that you order the critical care card. In fact, if you have a complicated infection like that and the patient is in ICU, I would suggest that you order it straight away upfront when you're sending the culture itself. Ask for critical care AST to be done so that you will get the polymyxin and colistin MICs, and you will also get the information regarding ceftazidime avibactam. It is not that all pseudomonas are resistant to ceftazidime avibactam. Some of them are susceptible, and that information is worth having. So critical care card AST, definitely.
Okay, ma'am. So for this patient, we'll be going with a critical care AST for polymyxin colistin and to discontinue with the ceftazidime avibactam. And also there was an ampicillin sulbactam, which they were suspecting the crab. To stop that and to add on with meropenem and polymyxin for the treatment. Okay, can we move on to the, I think all of you are agreeing with it. Can we go with that recommendation?
Yeah.
Yes.
Yes, yes. So moving on with the last case of the day, the third case.
Yeah, discussion. If you want to highlight any points in the discussion, you can do that.
So the next case is, this patient is a 75-year-old male patient admitted under the head and neck surgery department. He's a case of squamous cell carcinoma of the nasal vestibule. He was referred here for wide local excision of the same lesion and was admitted on 1st November for the surgery. Surgery done was wide local excision plus paramedian forehead flap under anesthesia on 10th November. It's a known case of type 2 diabetes mellitus, hypertension, Parkinson's, and cerebrovascular accident. He's a bedridden patient since 8 months. He had complaints of nasal vestibular swelling since 2 months and was diagnosed with squamous cell carcinoma of the nasal vestibule. On 15th October, the MRI showed enhancing lesions in the lateral wall floor of nasal cavity involving cartilage and facial muscles and upper lips. The clinical parameters of the patient has been bedridden and has Foley's catheters from outside, which was changed 2 days back after admission here. His CRP was elevated on admission and it was downtrending. And WBC was also elevated and it was downtrending after admission. They sent urine cultures and from 8 November, and it yielded Enterococcus species, which was vancomycin sensitive and Candida tropicalis. Urine routine from 8 November also showed yeast cells, trace leukocytes, but no bacteria. And this is the culture and sensitivity of the Enterococcus and Candida. Enterococcus was vancomycin susceptible. So after sending the culture, they started the patient on tab nitrofurantoin 100 mg BD, and they stopped it when they found the sensitivity report, and they hiked it to cap vancomycin on 11th November 500 mg BD. So from a stewardship point of view, the only indication for oral vancomycin is for Clostridium difficile infections, and the patient was not having any complaints of loose stools. And also the patient was having asymptomatic bacteriuria, no fever episodes or urinary irritations were there. So,
Okay. So now we have a case of asymptomatic bacteriuria, which was being treated with capsule vancomycin. So, sir, your thoughts on this?
Yeah, I mean, maybe Dr. Nandita, you can take and then I will add on.
Okay.
Yes, ma'am.
Okay. Yeah. Since the patient has been catheterized for a few days, so it's almost like when the catheter has been in place for a few days, more than a couple of weeks, there's almost 100% chance that it will be colonized. So it is better to, I mean, if there is an indication to send a urine culture, if the patient is symptomatic, it is better to send at the time of changing the Foley's catheter. Also, here you have if it's an asymptomatic bacteriuria, first of all, whether that culture needed to have been sent at all. And if you have an asymptomatic bacteriuria, there is no indication for treatment unless you have a pregnant patient, or if you have a patient who is post-renal transplant, or if the patient is undergoing a urological procedure. So apart from those indications, there is no need to treat an asymptomatic bacteriuria.
So that summarizes the classical points related to asymptomatic bacteriuria. Again, we know this patient, what is the clinical syndrome? The patient presented with some kind of lesion in the head and neck area, they did surgery. So what are the complications we are anticipating in this patient? Maybe a local infection, or if there is swallowing difficulty, some kind of aspiration. UT is the last thing we are going to suspect in this patient. And why did they send urine culture? That is the that itself should be questioned. So that will come under the ambit of diagnostic stewardship. Are we sending the right samples? Are we suspecting the right syndrome? If we are not, then our diagnostic, there's a problem with the order of the diagnostic test. Just because we have some test in-house doesn't mean that we need to do all these tests. So probably what happens is that in this kind of ICUs, it may not be a critical care intensivist or a physician who is taking the decision. Sometimes it might be one of the junior doctors, and they might see some precipitates in the urinary tube and they will mistake it for a urinary tract infection, and then they will Okay, because there is so much puzzles. It may not be puzzles. It might be just precipitates. Okay, there is so much puzzle. So let's try to understand what is happening. So they will send the urine routine and urine culture. And again, look at the scenario. The patient is asymptomatic, no urinary symptoms whatsoever. And look at the urine routine. The puzzles is only trace. There is not enough puzzles also. So there is no cystitis as well. So completely a case of asymptomatic bacteria. And then Dr. Nandita already said, no need to treat asymptomatic bacteria. And if you are deciding to treat, what are the 3 scenarios where you have to treat asymptomatic bacteria? So that is taken care of. And again, I just want to highlight the importance of trying to understand whether even before we interpret a test, whether the interpretation of the test or whether the sending of the test in first place is really required or not. So stewardship activities will be best delivered if we could clinically correlate and decide if this particular test requires our attention or not. So that should be our starting point. If only if we have that kind of thought process, we will be able to pick up scenarios like asymptomatic bacteriuria, and whatever antibiotics they had given, we will be able to stop it. Here, even if it is asymptomatic, even if it is symptomatic bacteriuria, the drug of choice were wrong. I think they were giving cap vancomycin, right?
Yes.
Yeah. So they cannot give cap vancomycin, even if they were suspecting something like enterococcus. Enterococcus, the algorithm is whether it is ampicillin sensitive or ampicillin resistant. If it is ampicillin sensitive, give ampicillin. If ampicillin resistant, give vancomycin. And vancomycin is IV. Vancomycin is not a drug which gets absorbed. So even if it was an enterococcus and even if it was a symptomatic bacteriuria, the choice was wrong in this particular scenario.
Thank you, sir. And Subhay sir, how common it is to encounter with unwanted urine cultures being sent from the ICUC?
Yeah, it is unfortunately fairly common to find urine cultures sent. And what Deepu had mentioned is exceptionally important, that we should be looking at the right cultures to be sent, and should we be actually interpreting this the positivity of the urine, positive culture of the urine that was sent. Anyway, one of the things that we need to also understand is, especially in the ICU settings, when you get asymptomatic bacteriuria, is that if possible, take the Foley's catheter, the urine catheter out, and not put at all if possible. Sometimes it may not be possible, in which case your options include inserting another new Foley's catheter or maybe condom catheters. So these are the options that we've got, which we should be looking into in these patients. And sometimes patients, if they are bedridden, say after stroke, etc., then maybe a suprapubic catheter, etc., should be other things that should be considered for someone who's get recurrent problems in this aspect. So those are the options that should be considered in such scenarios. Thank you.
Thank you, sir, for enlightening us again on how the infection control aspects also happen as part of antimicrobial stewardship. So for this patient, Andram, I think we'll go with a recommendation where we would be saying that oral vancomycin is not indicated here and it's only for Clostridium difficile. And to stop this, as the patient is not having any such symptoms of loose stools or anything, and the patient is having an asymptomatic bacteriuria. Yes, Andram, and we'll be following it.
Yeah, Anandram, any points to
Yes, sir. I think this was a rather interesting case because not many people know whether IV vancomycin and oral vancomycin works the same way. So the only indication for oral vancomycin is for Clostridium difficile infection, and I think we need to give away this information to the healthcare people. Because most of them think that these formulations are not important, because in every scenarios we can see there are a lot of formulation which can be available in both tablet and IV formulation, which can be given for the same treatment. For example, we can give linezolid oral tablet and IV for the same MRS infection, for an example. But in case of vancomycin, it is not possible. And so I rather find this interesting case, and this is one of the main stewardship recommendation we can keep for a case like this. So that's all. Thank you.
So now we had a real-time experience. Yes, sir, please.
Yeah. So just to conclude the point, Anandram has touched upon the very important point of bioavailability. So any drug, if you want to give us a systemic drug, always ensure that there is adequate bioavailability. Vancomycin bioavailability is 0 when given orally, whereas in case of linezolid, bioavailability is also almost 100%. So that concept of bioavailability will be very important when deciding to give oral antibiotic for a systemic course.
Thank you, sir, for adding that point. So now we had a real-time experience of how stewardship happens and the importance of having a multidisciplinary team to it, how each of them are adding value to the whole of the program. Thank you all for joining, and special thanks to the Mr. Nandita ma'am, Subir sir, Anandram, and the steward of the day, Soundarya. Thank you all for joining. I hope this enlightens others and inspire others to start stewardship in their respective hospitals. Yes. Thank you.
Thank you so much. Thank you.
Thank you.
Thank you.